I believe my symposium's working today. We'll see how long that lasts. They had a Board of Trustees meeting in this room, and they utilized all of this, and it might be behaving or it might be misbehaving based upon what those other people did to my computer here. And I say mine because you know how it is, guys. Yeah. Your technology, you get a little attached to. Okay. This topic here is the ovarian cycle. So what we are talking about is what's happening in the ovary. And right here is the ovary. And the ovary starts to undergo changes on a cyclical basis at what time in a woman's life? Puberty. So this is all related to puberty that we're actually talking about. And when do these cyclical changes go away? At menopause. So all of this is during that time of fertility for the woman. Puberty to menopause. Now, there is irregularities in the cycles at the very beginning of puberty and at the very end of menopause, but that's because that's the timing out of the whole process. Now remember, we are sticking with the perfect female. There's no such thing, but we're going to say every 28 days. And there are some women that definitely cycle every 28 days. But remember, I told you there are women that cycle every 3 weeks and every 3 months. And I was, for a long time, I was every 3 months. Then I became every 3 weeks, and we took that puppy out. So, for other reasons besides that, obviously. You guys will be doing cadaver review, and you'll see that our lady has just an ovary left. And so hopefully the students will ask you, why does she have an ovary? And you'll be able to figure out that it's based upon where hormones come from for a woman. And indeed, they do come from the ovaries, but they come from the ovaries when the time is right. So puberty is the beginning, and then menopause is the end. And gonadotropins are going to be responsible for the hormonal cycles, and therefore the follicular cycles that you'll see in the ovary. So gonadotropin-releasing hormone, GnRH, is going to cause the release from the anterior pituitary FSH and LH. FSH stands for follicle-stimulating hormone, and that's the big player here. FSH is super duper important, the big player, because it does what its name implies. It stimulates follicles to grow. And so FSH is a recruiter, so to speak, in the ovaries, and it will go to the ovaries and it will go to a group of primary oocytes, because in the ovaries, remember now, they are completely populated with primary oocytes. And when you hear the word primary oocyte, is this a mitotically active cell or a cell that's in meiosis in suspended animation? So it's in meiosis in a suspended state. And so one of the things that I told you earlier is that the ovaries will undergo mitosis of the oogonia until the population is established, the proper population. That's several million. By time puberty hits, we have 500,000 oocytes left. So that time where they're put in suspension, where they don't go any place but have to stay in meiosis 1, there's a lot of attrition or loss of those oocytes. So gonadotropin-releasing hormone is going to increase with a certain level of estrogen and progesterone. So let's take a look at the chart down below, this guy down here, and tell me, what can you say about the estrogen and progesterone levels at the beginning of the cycle? Compare them to the rest of the cycle. Tell me what you see when you take a look at that graph. High, low, in between, what? Low. So that's exceedingly important. Low estrogen and progesterone levels are necessary for gonadotropin-releasing hormone to be released, because high estrogen and progesterone levels inhibit actually the release of gonadotropin-releasing hormone, as well as follicle-stimulating hormone and luteinizing hormone. So gonadotropin-releasing hormone is going to cause the release of FSH and LH, and The stimulus for this is low estrogen and progesterone levels. So now, follicles, FSH, are going to be stimulated to go from a primordial follicle, which is stuck in that suspension of meiosis 1, suspended state of meiosis 1, and FSH is a recruiter, and it's going to go, say, to a group of primordial follicles that have primary oocytes in them. That I want you, this group of 20, and I'm just going to use 20 because it's an easy number. Okay, I want you 20 primary oocytes to develop into follicles. And when you develop into follicles, those primary oocytes are also told, I want somebody to finish meiosis 1. So of you 20, all stuck in meiosis 1, one of you is going to win this race. Because we're recruiting for a race where we end up with one oocyte that has completed meiosis 1 and is therefore called a secondary oocyte. And that's the secondary oocyte which is ovulated. Okay. So we want one egg to be ovulated, but we're recruiting a group of 20, and we're going to find out who's the best player or runner, so to speak, in this process. So FSH will stimulate a group of primary follicles, primordial follicles, to become primary follicles. And remember, now primary follicles, instead of simple squamous epithelial follicular cells, we now have these cuboidal cells, and cuboidal cells always do something. One of the things that's important, when we talked about glands previously, most of our glands were had cuboidal cells. So cuboidal cells do something. And these cuboidal cells are responsible for producing, let's go ahead and take a look now back at this chart down here. What level of hormone goes up? Estrogen. That's what those cuboidal cells do. They produce estrogen. Those are granulosa cells now. When your follicle cells become cuboidal, they're turned into granulosa cells, and the predominant hormone that they produce is estrogen. And if you'll follow this graph here, estrogen levels rise. So that means we're getting more and more granulosa cells. And so we have this batch of primary follicles developing, but somebody's going to do a better job and become a secondary follicle. One of this group of 20 is going to really outshine the others. The others are going to be putzing along. And so when they putz along, and when we finally get to that secondary follicle, which is what we can see in an ovary, the other guys are going to die. Because take a look at what happens to the FSH levels as we go from secondary to mature follicle. The FSH levels drop. And those putzing follicles need somebody to kind of push them along, need that FSH pusher. Well, if FSH is not there to push them along, they just wander aimlessly, essentially, in that area of the ovary, and then they atrophy. So FSH goes down because secondary follicle has a whole bunch of granulosa cells, and as you take a look at that estrogen level, it keeps rising, and that mature follicle, which is the one to be ovulated, also called the vesicular follicle, which means it's really a hormone-producing machine, because that's one of the things that you have to realize. This vesicular follicle is the one responsible for that peaking estrogen level. So it's an estrogen-producing machine. All those granulosa cells are. So those estrogen and progesterones have a definitely inhibitory effect on estrogen right now on FSH. So we see that drop in this FSH here. Doesn't seem to do too much right now on LH, but definitely on FSH, which is important for the aimless follicles to develop. So they can't develop without that FSH. But because this mature follicle now has essentially gone in and has essentially completed meiosis 1 and is now, the egg in the middle is called a secondary oocyte. Remember, primary oocyte goes into meiosis 1, comes out as a secondary oocyte, and goes into meiosis 2. Okay. So now we have that mature follicle. It's going to ovulate because of this, the peak in the estrogen, because that peak in that estrogen will cause now this lovely LH surge. And that LH surge is responsible for ovulation. Now that we have lost the egg that we call the ovum because of ovulation, so we'll coincide the term ovum to an ovulated egg, which is now a secondary oocyte. Secondary oocytes automatically go into meiosis 2 and get stuck again. They get stuck in meiosis 2 and will not complete meiosis 2 unless fertilization occurs. Let's take a look, though, at what's left behind, the corpus luteum. The corpus luteum used to be the granulosa cells. They used to be estrogen predominant. Take a look at what happens to the estrogen levels after ovulation. They drop. And that's because granulosa cells are shifting gears. They're shifting gears to become the corpus luteum and progesterone dominant. Take a look here. P, progesterone. We need progesterone after ovulation. Progesterone is going to be responsible for creating what's called the secretory phase of the uterus. This area right here. Take a look at how big and lush this is. This is creating the best petri dish for implantation of a fertilized egg. And so you need to prep the uterine lining, the endometrium, more specifically the stratum functionalis, for the possible invasion or implantation, however you prefer to look at it, of the fertilized egg, if we're going to get fertilization. If fertilization doesn't occur, then the corpus luteum will regress and become the corpus albicans. So that happens when no fertilization. So when we get regression of the corpus luteum and it starts to turn into the corpus albicans, that means there is no fertilization or no successful implantation. So this cycle that we see here, this 1 month cycle, is a cycle that is involving an egg that is either not fertilized or, if fertilized, does not successfully implant. So that's what we're actually seeing here. Take a look at what happens to the FSH and LH levels when progesterone is at the highest. What do you think about those FSH and LH levels? Pretty low. And that's important because progesterone stimulates the endometrial lining, but it inhibits the release of FSH and LH, and even gonadotropin-releasing hormone. It has a negative feedback on that. We also see in the second half of the cycle, we see our estrogen levels going back up. Again, remember I said that corpus luteum is switching to progesterone dominance. It doesn't mean it's not producing estrogen. It's switching gears to be a big progesterone producer because that progesterone is what's responsible for creating that secretory phase of the endometrial lining. If there is no fertilization or successful implantation, corpus luteum only lives for a max of 2 weeks. That's its programmed lifespan. If fertilization does occur with successful implantation, the fertilized egg will produce a hormone that is tested for when somebody is trying to find out if they're pregnant. Do you guys know what that hormone is? Yes. HCG, human chorionic gonadotropin. And HCG tells the corpus luteum you cannot die. So that's why successful implantation has to take place. if fertilization occurs, because then it will actually produce human chorionic gonadotropin, which will have a feedback on the corpus luteum and says, do not die. So what happens to progesterone levels if corpus luteum is not allowed to die? They stay up. Because what produces progesterone right now? The corpus luteum. So we keep the corpus luteum alive. That means we keep high estrogen levels. What does that mean to the endometrial lining? Stays like that. Stays like a lush force that is going to be able to provide nutrients to the developing embryo. So that's what this whole cycle is about. That's why you have to realize we have things going on in the ovary that is going to be dependent upon our gonadotropin levels, FSH and LH. And when we have follicles developing, that directly impacts hormone levels, because hormones come from follicles and corpus luteum, correct? Hormones come from the granulosa cells of the follicles, and they also come from the corpus luteum once ovulation has occurred. The difference is that the corpus luteum is after ovulation, and we're a different hormone factory. Hormone levels will have a direct impact on the uterine lining. Because take a look at our day, the beginning of a woman's menstrual cycle. Day 1 is easy to identify, and that's because menses starts or bleeding starts, and so it's an identifiable event. So we choose that for the first day of a cycle. And we had a stratum functionalis that was very secretory and very, very rich and everything, but because we don't have progesterone to maintain it, see how it's dropping here? We lose it. And so the sloughing occurs. Progesterone is necessary for maintenance of the uterine lining. Before puberty, what's the uterine lining look like? Does it look like anything like this bottom diagram? Not. Okay, so this bottom diagram, the uterine cycle here, is all based upon the cyclical estrogen and progesterone levels. So the uterine lining is dependent upon estrogen and progesterone. And when there's no estrogen and progesterone, this uterine lining is very thin. That's pre-puberty and postmenopausal. And so therefore, will you slough anything? No, there's nothing to slough. So understanding the interrelationship of these four diagrams here is important to getting the cycle and the various components figured out. Let's go ahead and fill in some notes. Follicular phase. So right now, when we talk about follicular phase, we must be talking about an ovary, because where are follicles? In the ovary. So follicular phase is day 1 through day 13, and we're using a 28-day cycler. And this is a time when our primordial follicles and notice I put an S, are recruited by FSH to become primary follicles. Again, I have an S there. Primary follicles are cells that are still in meiosis 1 and will become a secondary follicle. And if you notice, there's no S here. So this is a cell that's just about ready to finish meiosis 1. And hang on here. I try to make it look better and it always looks worse. And become a mature follicle, which means that we're going to complete meiosis 1 and become a secondary oocyte, which will then be ovulated. When we see an increase of gonadotropin-releasing hormone, we know that E and P are at their lowest. So no inhibition of GnRH release, which will cause FSH release plus LH release from our anterior pituitary, follicle stimulating hormone and luteinizing hormone. More specifically, we are interested in FSH. We want to stimulate some follicles. However, as estrogens increase, this has negative feedback on FSH. So those follicles that were recruited that aren't really performing well will wither away because FSH is needed to try and herd these guys in the right direction. Ovulation, or the ovulatory phase, we are releasing the secondary oocyte, and we'll call it an ovum. And the reason ovulation occurs is estrogens rise to a peak or critical level. Now we have suddenly positive feedback on LH release. That's the one that we're interested in. That's why I talk about it. There is FSH surge, but we're interested in the LH surge. And when we get that LH surge, that actually causes contraction and rupture of the follicle wall and the ovarian wall. Our secondary oocyte breaks free of ovary. In order for ovulation to occur, we have to break through the ovarian wall. You know, and when I say ovarian wall, what does that mean to you guys? What is in your mind when I say ovarian wall? What's the barrier to the outside world that this has to actually break through?
Mucous membrane.
Mucous membrane. Because think about the ovary. What's the wall of the ovary made out of? Take a look at your notes real quick. It's good. It's good to have you do something besides just write. Corpus albicans and, is that it? Is that all the wall of the ovary is? Corpus albicans is a scarred body. Is that what we're wanting to break free of, the scarred body? What's the structure of the ovary? We talked about in the very beginning of this. Germinal epithelium was misnamed as peritoneum and tunica albuginea. So all of those, what's really interesting, we have to actually break through what I call the wall, tunica albuginea, and germinal epithelium to be released into the peritoneal cavity, and hopefully the uterine tube and fimbria are right there to catch as that release actually occurs. So we have to break through that wall, and we are released into the peritoneal cavity for a moment. But as I said, if the fallopian tube or uterine tube and the fimbria are right there, they kind of create a little bit of a coaxing wave-like action trying to get that oocyte that's just now been ovulated, or ovum. They're trying to catch it like a baseball catcher with his catcher mitt. Gets it right in and takes it on down and lets it move on down the tube to the ampulla where potential fertilization can occur. So that's the ovulatory phase. It only takes a day for this to happen. The luteal phase is day 15 through 28 of a 28-day cycle, and this is the one that is the most constant. If a woman is not a 28-day cycler, the follicular phase is the one that's really variable. So if you're a 21-day cycler, the follicular phase is a week. If you're a 3-month cycler, then the follicular phase is 2.5 months. The time frame that's always the most consistent is the luteal phase. So this is the most constant or consistent. And remember, during this time, ruptured follicle collapses and becomes the corpus luteum, which is now going to switch to producing predominantly progesterone. Still produces estrogen, but the one that we need it to be the best at making right now is progesterone. Progesterone maintains uterine lining, maintains stratum functionalis, a lush stratum functionalis. Increased progesterone levels has negative feedback on FSH and LH. When you take a look at that previous chart up above. And why do we want to actually inhibit FSH? If we inhibit FSH, what means we don't have? What follicles developing? Okay, negative feedback on FSH and LH means follicles, no new follicles can develop. If we have a ovum that's ovulated and it gets fertilized, and implanted, do we want to have more of these follicles? The uterus is not designed in the woman. It's not designed for actually more than a singleton pregnancy. When you have twin pregnancies, what is the woman at risk for? Early delivery. What about triplets? Even earlier. What about quadruplets? Even earlier. What you have to realize is there is a limit to the size the uterine can expand to. And the bigger you ask it to get, the sooner it has to get rid of its contents. You follow that one? We're not like the cats. Cats have uterine horns. Those are actually like little peas in a pod. You can actually implant along those uterine horns. They are constructed for multiple gestations. Female uterus is not constructed for multiple gestations. It is constructed for a singleton gestation. Yes?
So the case of like the Octomom, did she
Sorry.
have kids like super early, or did they like
Yeah.
or just start full?
Yeah, she definitely delivered those kids very early. And do you think she was up and about like a woman that has a singleton pregnancy? No, no, she wasn't cleaning the house. She was she was a bedroom diva. Yeah. So, in our notes here, if no fertilization, what does that mean to the corpus luteum? Yeah, no fertilization, corpus luteum becomes corpus albicans. So that means P levels drop, which then means menses, right? If fertilized, then embryo, let's call it, I'm going to call it conceptus. Conceptus must successfully implant. And so if you don't have a lush uterine lining, you cannot successfully implant. So it must successfully implant and will produce HCG to cause corpus luteum to live for 3 months. The reason for this 3 months is after 3 months, placenta is mature enough to take over. And the placenta will produce progesterone and estrogen, as well as other hormones that we'll talk about with the next chapter. When do women miscarry? Most often. First trimester, first 3 months. So what that means then, if you miscarry, what do you know about progesterone levels? They dropped. So that corpus luteum and the production of progesterone is absolutely vital to the maintenance of any pregnancy throughout the entire pregnancy. And it's exceedingly vital, obviously, if you want a pregnancy to actually start and get past that first trimester. Now, if something's wrong with the corpus luteum and nothing is wrong with the fetus, progesterone levels will drop and a miscarriage will occur. If something's wrong with the fetus, it will eventually impact the corpus luteum, progesterone levels will drop, and miscarriage will occur. This is how the thing goes. This is how the cycle works to ensure that we have a satisfactory pregnancy and child. So there's a lot to the ability to actually become pregnant and actually to maintain a pregnancy. That has to happen here. Menstrual phase. Really short little story here. 3 phases in sequence. Remember what's happening with menstruation. We're talking about the uterus, and what's happening in the ovary directly impacts what is happening in the uterus. So, levels of progesterone, P and E, control this. Control uterine lining. In the menstrual phase, day 1 through day 5, that's menstruation or the shedding, it's 5 or 6 or 7, just depends upon the individual. What do we know about progesterone levels? Right off the bat. If you're menstruating, what do we know about your progesterone levels? Rock bottom, and so are your estrogen. So when you go ahead and take a look at the charts that we actually had above. So E and more importantly, P at lowest. Because that is the stimulus for the loss of the endometrial lining. The interesting thing, this is at the start. Take a look at your chart up above and see what happens with those estrogen levels during those first 5 days. Right along here. Are estrogen levels flat? No, they're starting to increase. And this is because gonadotropin-releasing hormone has been released, which means it's going to stimulate the release of follicle-stimulating hormone and luteinizing hormone, but we're more interested in follicle-stimulating hormone because follicle-stimulating hormones will cause what to start to develop?
Estrogen.
estrogen to develop from those granulosa cells, from all those little bitty primary follicles trying to get into the race. Okay? So even in the menstrual cycle, at the end of the menstrual cycle, the estrogen level is higher than it was at the beginning of the menstrual cycle. So EMP lowest at the start, but E is increasing gradually, especially at the end there. It's still starting to increase because of follicles, due to follicle development. Now, estrogen is directly responsible for rebuilding the endometrial lining, okay, getting the basic foundation up, because stratum basalis is still there. We just lost stratum functionalis. So now we need to replete that stratum, and we do that during the proliferation. Things proliferate and grow, and that's day 6 through day 14. I don't know why it doesn't do an arrow with this Word document. That's called the rebuilding phase. And this rebuilding phase is actually due to estrogen levels. And estrogen levels, as you look at this chart, they are indeed rising. Then the secretory phase, we're making product. When you secrete, you make product, okay? So we're beyond rebuilding. Now we can actually do even more. And that's day 15 through 28. Prepares the uterus for an embryo to actually successfully implant. And this is due to rising progesterone levels, which is due to corpus luteum activity. And remember, if no HCG, corpus luteum max lifespan is 2 weeks. And even then, it's dying at the end of the second week, isn't it? So it's starting to peter out in its progesterone production. And so max life without fertilization is 2 weeks. With fertilization and successful implantation, max corpus luteum life is actually, a good healthy corpus luteum life will be 3 months. And HCG is responsible for maintaining the corpus luteum. So it has a positive feedback, says live, produce more progesterone, produce more, so that we keep our endometrial lining lush. Female sexual response is the end of this portion of this chapter. This is all a physiological process. The hormone that's responsible for sex drive in women is actually DHEA. A lot of people think it's testosterone. It's dihydroepiandrosterone. So it's an androgen. And testosterones are generically considered as part of the androgen category. But DHEA levels are what actually control sex drive. You can substitute in testosterone and you will also promote sex drive, but then you promote other things, right? Because what is testosterone good for? In guys? Muscle and nice hairy face and nice deep voice. Yes, all of those good things. And also, you know, unfortunately, for some, a lot of acne too, you know, and so women will experience hair growth and all kinds of things with testosterone. So DHEA is actually the more physiologic type of hormone necessary for a healthy sex drive in women. With proper stimulation, a woman can enter into the excitement phase. This is going to be analogous to the erection phase for men, and it is going to be a parasympathetic, P/S is parasympathetic, plus sympathetic response to stimulation. Parasympathetic, what's really interesting. You guys remember which one of these two branches is responsible for vasodilation and vasoconstriction and blood vessel diameter? Do you guys remember? Sympathetic. Sympathetic only. Very good. So it's sympathetic only, except in the genitals. So the parasympathetic nervous system actually controls blood vessel diameter associated with the genitals of men and women. So I told you before, it's sympathetic, and it still is for basic functions, but for reproductive functions, it's parasympathetic that is responsible for blood vessel diameter. And so what's interesting, you will get vascular engorgement and vascular engorgement occurs with vascular blood vessel dilation of the breast tissue, of the vaginal tissue, of the clitoris, and of the labia even. There's actually more to this list, but I decided 4 is enough. So vascular engorgement. So they will actually increase in size and hue, so to speak. And this is because secondary sex organs and genitalia are actually going to have vascular changes with parasympathetic stimulation. The sympathetic response will be increased heart rate, increased blood pressure, and increased respiratory rate. With enough stimulation, the parasympathetic system will actually kind of hit a crescendo in its process, and an orgasm will occur, and pleasure with the release of tension and actual contraction of the uterus and vaginal wall will actually occur. And this aspect is a sympathetic only response. Then following that will be a resolution phase, which is the reversal of vascular engorgement. So then vasodilation will no longer be actually occurring, then normal blood vessel diameter will occur, and then the tissues will actually then relieve themselves of all of the vascular congestion that actually occurs in resolution. So that's that story. Let's go on and talk about men. Now that we've talked about women, when we talk about men, the story is actually simpler because we start off with the more complicated process of taking, most people will tell you women are rather complicated. And if you take life with a grain of salt, you'll actually kind of laugh about it and say, yeah, they really are, especially if you talk about anatomy and physiology aspects of things. For men, the process is simpler. For women, we're trying to actually create an egg that will live, a fertilized egg, that will live for 2 weeks so that we can actually take this thing that's going to go through meiosis and create a huge giant cell that will get fertilized and live for 2 weeks as it traverses the reproductive system of the woman for implantation in the uterine lining successfully. So it has to have all kinds of machinery already on board for it to actually do this. So we want to go from 1 to 1, 1 to 1, not 2, 1 to 1. With men, when men undergo meiosis, they will go and they will, because meiosis is a meiosis 1 and meiosis 2 process, they'll go from 1 cell to 4 cells. With mitosis, remember we go from 1 cell to 2? So meiosis has similarities to mitosis, except it produces haploid cells. Haploid means 1 set of chromosomes. And we go from 1 cell to 4 under ordinary circumstances. And if you actually take a look at that process where we get polar bodies, when we go through meiosis 1, we get a secondary oocyte and 1 polar body, correct? Isn't that 2 cells, so to speak? If that second cell actually had the ability to actually do meiosis too, but it doesn't because it doesn't have enough machinery with it, that polar body could theoretically create another two polar bodies. And so if that were to occur, theoretically we would get one egg and 3 polar bodies, which would be that 1 to 4 final production. But we're only interested in one. We want one outcome for the female system. For the male system, we want to actually maximize our ability to get there successfully for fertilization. And so when we actually go through reproduction, a large amount of spermatozoa will be deposited into the female reproductive tract, and barrier after barrier after barrier after barrier has to be breached. And when you have that type of a system, you will have a lot of attrition. And so while millions of sperm cells will be deposited into the female's reproductive tract, only a few hundred will actually get to the egg successfully for fertilization to actually occur. So we have to have in the male system a lot of spermatozoa produced in order for that process to occur. Let's go and start with the most external aspects of the male reproductive system, which is the scrotum. Our notes here say a pouch of skin that is designed essentially to house the testes. And indeed, it is functioned to keep the testes a few degrees lower than body temperature. That is because for meiosis to successfully occur in the testes with the gametes that are being produced there, we actually have to have a cooler temperature. So this is necessary for spermatogenesis. Or formation of male gametes. We will find associated with the scrotum 2 distinct muscles. One is called the cremaster muscle, which surrounds the testes. The other is the dartos muscle, which is within the scrotal wall. So it's actually part of the scrotal sac itself. So the cremaster muscle is around the testes, and the dartos muscle is within the scrotal wall. And when they contract, what will happen to the testes? They'll be brought closer to the body wall. Well, what will that do to temperature? It will actually raise it. And so based upon the environmental temperature, we have to have the testes a few degrees lower than body temperature for spermatogenesis to occur. And that's what these two muscles are for. Why do we have two muscles for this? Why do we have two of anything? It's a backup system. Absolutely. This is indeed a backup system. So they both can contract, or one or the other can contract, right? So we have a nice backup system with this. Now, what about an undescended testicle? What does that mean about fertility for that individual? No good. They will not have normal gametes being formed. So they will not have successful spermatogenesis. So if a testes is undescended, it means it's in the abdominal cavity, and it means that it's at body temperature and will not have spermatogenesis occurring. It has to be a few degrees lower. And so the important thing about the testes is that they start in the abdominal cavity. You guys remember where the testicular arteries were in your cats and stuff? Weren't they up kind of high, close to the kidneys? Well, guess where the testes start? The testes start high in that area, in the abdominal cavity. And so during embryogenesis and the maturation of the fetus, the testes actually start a trip down into the pelvis. So they gradually stretch out their blood vessels, and anything done gradually is easily tolerated. They'll stretch out their blood vessels. They'll go all the way down into the pelvis. And then from the pelvis, the testes will actually then make a trip through the inguinal canal. The inguinal canal has an internal ring and an external ring. The internal ring is more laterally located, and the external ring is more medially located. And this is something that is tested for hernias, correct? In sports physicals, they'll actually do a test where they'll actually, the person examining the individual will put their finger up into, externally, up into the area where the external ring is located and ask you to cough. Because if you cough and there's any patency or openness of that inguinal canal, things from the abdominal cavity can come through. Because that's how the testes got out. The testes, anything inside the abdominal cavity is covered with what type of peritoneum? Any organ in the abdominal cavity is covered with what type of peritoneum? Visceral peritoneum. What's the abdominal cavity covered by? What's the name of that peritoneum? Parietal. So what the testes do is when they get to the internal ring, they push through the parietal peritoneum, carrying it with them, go down the inguinal canal and exit out the external ring with that peritoneal lining. That's what creates the spermatic cord and is also what creates what you guys learned as tunica vaginalis. That is the normal descent. After they exit the inguinal canal, that canal actually collapses and closes, unless of course it's patent and then you actually can have inguinal hernias. So let's go ahead and add to our notes here. Cremaster muscle and dartos muscle are designed to help modulate the temperature of the testes. Testes, referred to as primary sex organs or male gonads, because they produce hormones, which we know is testosterone, and gametes, which are going to be spermatozoa. You guys identified with your cat 2 tunics associated with the testes, tunica vaginalis, the outer layer, which comes from peritoneum. And more specifically, the parietal peritoneum. That's what tunica vaginalis is. Tunica albuginea, that indeed is the true surface of the testes. It has CT extensions because it is fibrous CT. Into the testes to create lobules. And there are approximately 300 per testes. In the lobules, in the testes, are the seminiferous tubules. Our notes here say they're tightly coiled tubules. Tubules means really small tube. That is the actual site of sperm cell production or spermatogenesis. We'll have 1 to 4 seminiferous tubules per lobule. The seminiferous tubules will empty their products into what are called the retete testes. And the retete testes is a reticulated area, and they will empty their contents ultimately into efferent ductules. Remember, efferent means to take away or go away from. And the efferent ductules actually drain into the epididymis, which is a storage reservoir for spermatozoa as they work on maturation. The spermatic cord is a CT sheath enclosing BV, blood vessels, nerves, and the cremaster muscle, because remember that's what goes around the testes, and the ductus deferens. And that spermatic cord is going to also be part of the peritoneum. Sheathing everything. So let's take a quick look at the cartoon and then also at the histology. Because this histology here is the best histology you'll find for actually the seminiferous tubules. It has the best identifiers in it. Okay, here's our testes. Here is the outer aspect, which is the tunica albuginea. Tunica vaginalis has a visceral layer as well as a parietal layer. So visceral is right there on top of the tunica albuginea, parietal layers creating a space, because remember visceral and parietal, we have a space in between them. So that's an area. We have a bunch of lobules here that contain seminiferous tubules. This here is the reteat testi area. Here's the efferent ductules draining into the epididymis. The epididymis has a head, has a body, and a tail. And look where the head is. The head is superiorly located. The tail is inferiorly located. And coming off of the tail of the epididymis is our ductus deferens. So the ductus deferens starts down there. It becomes less squiggly as we get closer to the head of the testis area. But the ductus deferens starts at the end of the tail of the epididymis. Cross section of a seminiferous tubule. This is lumen. And along the wall is where we find mitotically active cells. So mitosis is going to occur in this area, and then meiosis is going to occur deeper on into the lumen. Being able to identify these cells are very important for adequate histology preparation for yourselves with the lab practical. Once we get done with the various stages of spermatogenesis, remind me to come back to this and I will point out the various cells that are actually present here for spermatogenesis. Let's take, man, we're moving along fine. You guys are looking pasty right now. All right, the duct system. So now we're outside of the testes and we have here a sagittal first and then below it a frontal view. This is the bladder, B for bladder. This is our ureter right here. And here is our ductus deferens. And in the human, just like the cat, it courses medial to the ureters. It does that on both sides. Again, T for testes, head, body, tail, and the beginning of the epididymis down there at the base of the tail. As the epididymis courses superiorly and into the body cavity, because that's what this area is actually referring to, it's going, we're looking up through the inguinal canal. It will enter into the pelvis and circle around the ureter medially and then join up with what's called the seminal vesicle, which is going to help to create material to help mature and prepare the spermatozoa for fertilization. So the seminal vesicle and the ductus deferens will come together to form the ejaculatory duct. In the area of the ductus deferens by the seminal vesicle, there is a swelling, and we use that term again, ampulla, of the ductus deferens. So that swelling means that actually more spermatozoa are in that area. The ejaculatory duct, if you'll notice, is in the prostate gland. So here's the ejaculatory duct. It meets up with the prostatic urethra in the prostate gland, and spermatozoa are then deposited into the urethra with proper ejaculation, are deposited into the prostatic urethra and then into the penile or spongy urethra, and then will traverse that area during ejaculation. So the prostate gland plays a role in this process. Inferior to the prostate gland is a gland called the bulbourethral glands. And remember the bulbourethral glands with the cat? So the bulbourethral glands are also present in the human male. The seminal vesicles were not present in the cat, but they are present in the human male. And the bulbourethral glands will help to form what's basically called the pre-ejaculate, to help actually lubricate the ejaculate through the urethra. Let's take a look at a posterior view. And I know this is a posterior view because of the ureters going into the bladder. Now those ureters to me are a little high because they should go in closer to the base of the bladder because of that trigone area at the base of the bladder. So it's a little misleading. But still, here's head, body, tail of the epididymis. Here's the beginning of the DD, ductus deferens, or also you can call it vas deferens, which is what most people are used to calling it. Again, showing how it curves around the ureters medially and then has a swelling called the ampulla, which comes together with the seminal vesicles to form a very short ejaculatory duct, which is completely within the prostate gland, to put contents into the prostatic urethra. The prostatic urethra will then give way to a new area of urethra called the membranous urethra. Right here, the membranous urethra is very, very small as far as length goes. And the reason it's called the membranous urethra is because that's the muscular sling that makes up our bottom. So our bottom, or perineum, between the legs, actually has muscles down there, but it's a thin layer. Otherwise, if we didn't have that, you guys remember pelvises. What keeps things in? Something's got to keep them in. It's a muscular sling, and we call that area the urogenital diaphragm, but the urethra that goes through that is called the membranous urethra. Then as the urethra goes through the body of the penis, we call that SU, or spongy urethra. We can sometimes call it penile urethra, but we're going to call it spongy urethra, and we'll get into the reasons anatomically why in just a little bit. Let's fill in some notes here. Epididymis. So seminal vesicles, reteat testes, efferent ductules, epididymis. Epididymis is interesting. Alongside the side of that testes, it's about 20 feet long. If you were to actually pull out the tube out of that, it'd end up being 20 feet long. So that's a super small tube that's really coiled up into that. And this is the area where we store sperm for maturation and the ability to fertilize an egg. So lies along the backside of the testes. Again, has head, body, and tail. It stores sperm cells. And they also mature here. So the sperm cells have to go quite a process of grooming for fertilization, and this is the beginning of the grooming process for successful fertilization. Ductus deferens is only 18 inches long. not very long at all, extends from the testes, the inferior pole of the testes, into the pelvic cavity and terminates at the prostate. In an area that is enlarged or swollen, and we call that the ampulla. This is designed to transport sperm into the ejaculatory duct. In order for sperm to be transported then, what do you need to move them along? If it's designed to move them, what do you know is part of its construction? Muscle. Smooth muscles in the wall, and peristalsis is necessary in order for this to actually occur. So that's why I say designed to transport sperm into the ejaculatory duct. So it does indeed have a nice smooth muscle wall that will undergo peristalsis in order to move sperm cells into that ejaculatory duct. And so that's why it's an easily identifiable structure in the spermatic cord. That's why vasectomies can be done, because it's got smooth muscle in its wall, it's a duct, it's firm, and a vasectomy can be done because it can easily be palpated or felt through the scrotum, through the spermatic cord. And that's why incisions can then be, very small incisions can be made into the scrotum through the spermatic cord, and you can literally, by feel, go ahead and grab it and pull it out to do what a vasectomy is, which is interrupt it. So a vasectomy means you tie off to a section, 1, 2, and then you make a cut in between those two sections and then let everything go back into the scrotal sac. So that's an important feature, that it is, that smooth muscle is significant in that wall that makes it so easily identifiable by palpation or by feel. The ejaculatory duct, very short, 1 to 2 centimeters long. Interesting lining, pseudostratified ciliated columnar epithelium. Connects the ductus deferens, or the ampulla of the ductus deferens, and the seminal vesicle in the prostate, and will then empty contents into prostatic urethra. So urethra, again, mentioned earlier, is divided into 3 regions: prostatic urethra through the prostate, membranous urethra through urogenital diaphragm, or pelvic floor, if that works better for you. That's muscular. And then the spongy urethra is going to be through the penis and very specific tissue of the penis. What's interesting, the bulk of semen, which is what is ejaculated, is produced by actually accessory glands. The seminal vesicles will contribute to the ejaculate or semen. So will the prostate. It will contribute secretions to that. And then the bulbourethral glands will also contribute secretions to the ejaculate. Seminal vesicles are located on the posterior wall of the bladder and create 70% of the semen volume. And happens to be alkaline as far as its pH goes. Secretions will empty into the ejaculatory duct to mix with the sperm cells. And these secretions will provide nutrients for sperm. And these nutrients are going to be fructose. Also, part of the secretions are going to be some prostaglandins. The prostaglandins are going to be important in helping with the dilation of the cervical os. So they have to get through the opening. And so with the secretion is a chemical that will actually help to open the door, so to speak, to allow the semen actually into the uterine cavity. We'll stop there and do a couple clicker questions and finish this chapter off and get into the reproductive chapter probably next time. So do bring those notes. And they are ready for you to actually print off online.